welcome to City Club of Portland Friday Forum. City Club is where we bring civic-minded people together to make Portland and Oregon a better place for everyone to live, work, and play. I'm Karen Curvin, president of City Club, and I would like to welcome members and guests alike, those of you who join us at Sentinel Hotel, and those of you listening on OPB Radio or watching on Portland Community Media. The generous support of City Club's corporate and media partners ensures that we put on the state's best civic programs week after week. I'd like to thank our media partner, Oregon Business Magazine. Our current Friday Forum sponsors are Bank of the Cascades, Family Care Health Plans, Legacy Health, Russell Fellow Properties, The Standard, and Stoll Reeves. We are grateful for your support and commitment to City Club's mission. Please join me in a warm round of applause for all of them. We are kicking off the new year with a great set of Friday Forums and after-hours events. Join us on Monday at the new Copper Penny in East Portland for an event focused on the urban renewal of Lentz. Next week's Friday Forum will be part 2 of our series looking ahead to the 2015 legislative session. Racial justice leaders from APONO, CIO, Urban League of Portland, and Western States Center will discuss their priorities for the next session. After today's program, please stay to debate and vote on the Healthcare and Homelessness Report. The event is open to everyone, but only City Club members can debate and vote on the report. If you're not staying for the debate and vote, please turn in your ballot as you leave. And again, if you did not receive a ballot, please return to the registration desk to get one. You can learn more about City Club events, purchase tickets, and become a member on our website, pdxcityclub.org. As always, we will be live tweeting today's program. You can follow along and join the conversation using the hashtag PDXCityClub. David Saracen will facilitate a Q&A session with the audience and our speakers at the end of today's program. Members, please come to the microphone to ask your question. For all of our audience members, please locate the index cards on the center of your tables and write your questions on them during the forum. Hold your cards up high and City Club staff will collect them prior to the start of Q&A. And now for our program. Homelessness remains a complex public health challenge. For too many individuals, the relentless struggle for safety and stability overshadows health needs. Common illnesses are allowed to progress and minor injuries fester until they become emergencies. Challenges in caring for those experiencing homelessness reveal deep fault lines in our current healthcare system. Today's forum will discuss City Club's newly released report on healthcare and homelessness and the issues we are facing as a community. Joining us today, we have Crista Gardner, chair of the research committee who produced the Healthcare and Homelessness Report, Dr. David Labby, the medical director of the largest coordinated care organization in Oregon, HealthShare, who has done a lot of work on primary care, medical homes, and other policy work that impacts the future of healthcare in Oregon. Dr. Rachel Solotaroff, the medical director at Central City Concern. She directly provides medical care to many homeless people in Oregon, with one of the largest service providers in the metro area. And Leo Rhodes, vice chair of the report and board member of Street Roots. Moderating today's program is David Saracen from the Oregonian. He has written many articles about poverty and hunger in our community. Please join me in welcoming our guests to the stage.
Hello. Thank you for attending this event on this very important subject, and thank you especially to those of you who are in the audience who provide healthcare services and social service to people experiencing homelessness. It's really important work, and I thank you for it. As you know, in January of 2014, the Affordable Care Act expanded Medicaid eligibility to those with incomes at 138% of the federal poverty level. That means a quarter of Multnomah County residents and almost all homeless individuals. Therefore, the City Club commissioned a report, the Healthcare Reform and Homelessness Report, to focus on ways to strengthen the implementation of healthcare reform for the homeless population. Over a course of 8 months, our committee of 15 City Club members and volunteers spent countless hours to research, interview, and write this report. We interviewed over 20 witnesses, including public officials, homeless advocates, healthcare and social service providers, county employees, people who work in coordinated care, and on the street, we interviewed persons experiencing homelessness. In the next few minutes, I'm going to talk about what we learned. Our committee understood that the issues of healthcare and homelessness are as deep as they are broad. So this report narrowly focused on Medicaid expansion for the homeless population in Multnomah County and the potential for positive change. First of all, the expansion of Medicaid has made health coverage a reality for many people experiencing homelessness. 1 in 4 residents of Multnomah County, including most homeless individuals, are now eligible for the Oregon Health Care Plan. Outreach workers have tirelessly worked to enroll the homeless through food stamp programs and anytime they were in contact with hospitals, jails, or social services. And efforts to enroll the homeless population have largely been seen as a success. Before the expansion of Medicaid, the homeless accessed healthcare treatment through social service and healthcare nonprofits, Multnomah County clinics, and emergency departments at hospitals at a really high society cost. Today, people experiencing homelessness have the opportunity to access care to which many of them haven't had in years. Primary care and specialty care, including mental health and substance abuse care. The success has been so great, in fact, that providing specialty care can sometimes include wait time. And the nonprofit healthcare providers are getting reimbursed for their services. For example, at Outside In 2013, only 17% of their patients had insurance, and today it's 70%. This new power to be a consumer provides both freedom and confusion and requires additional education and healthcare literacy for the homeless population. Secondly, it's difficult to become healthy when you're living on the streets. Ibrahim Mubarak, founder of Right to Dream 2 encampment downtown, stated, "When we go under the bridge, we see the conditions of the people living there. It's not a clean condition. There is no porta potty. There is nowhere for them to throw their trash when they eat. There is no place they can take a shower or shave or clean their clothes. In these conditions, common illnesses and minor injuries progress until they become emergencies. Simple things as skin infections or foot injuries become life-threatening emergencies. On the street, chronic diseases are difficult to manage. Half of the homeless population self-reports having a disabling condition. These could include chronic diseases that are more prevalent on the street, such as tuberculosis, frostbite, or hepatitis C. Or these could be other chronic conditions such as heart disease or diabetes. Imagine for a moment, if you will, trying to manage diabetes without a fridge in which to store your insulin. This access to might be what considered little things, such as a fridge to store your insulin or wound care, are tremendously important to people experiencing homelessness. And due to the rough conditions on the street, the average lifespan of a person experiencing homelessness is 30 years less than a person that is housed. And unfortunately, many of these people experiencing homelessness have negative institutional experiences, for example, with foster care or with the justice system, and have experienced traumatic injury, which makes it difficult for them to feel comfortable accessing health care. Greater education is needed for healthcare providers in trauma-informed care and in cultural competency in caring for the homeless population. Finally, the full potential of the Medicaid expansion is undermined by the lack of housing. Healthcare issues for the homeless are housing issues. Without adequate housing, individuals are at greater risk of poor health conditions, including complications of chronic illness, substance use, mental and behavioral issues, such as post-traumatic stress disorder. And housing is a critical social determinant of health. People experiencing homelessness would benefit from comprehensive wraparound services and supportive housing. And we have great examples here in the Multnomah County. For example, Bud Clark Commons and Old Town Clinic by Central City Concern. Medicaid expansions provide an opportunity to reallocate funding to address the root causes of health issues, such as homelessness. I want to thank you for your attention. The full draft report is available online at the City Club website. I also want to take a moment to acknowledge the great committee that put this together. If the committee would please stand to be recognized. The members of this committee are volunteers, and they spent countless hours in researching, interviewing, and writing this report. So thank you very much.
Crista, thank you. And I wonder if we could go a little further into what you were talking about, because we've discovered in other circumstances that simply qualifying for Medicaid or having an Oregon health plan card doesn't resolve your problems. There are still issues about finding providers. There are still issues about getting people to pursue prescribed regimens. And I wonder what other questions the simple expansion of Medicaid to a homeless population leaves us to deal with.
So there are many questions that this brings up. I mean, the first question is, how are the other social services wrapping around housing or in complementing the new expansion of Medicaid in order to best care for the homeless population? There is questions about outreach and outreach efforts in order to bring services to the homeless population. There are obviously questions about political will and funding for affordable housing in the Portland metro area. There's a myriad of different questions that can be brought up when it comes to homelessness and healthcare in this area.
So you're homeless and you now qualify for Medicaid, and you've got your card or whatever. Do you know where to go? Are you able to handle any paperwork involved? Can you follow a regimen that's been prescribed? Crista?
That's a great question, and many of the people that we spoke to, so we went out on the streets and we interviewed people experiencing homelessness, and many of the people expressed doubt or confusion on what services were being covered by Medicaid. For example, one woman had bipolar disorder, and she was being treated from mental health for that disorder, but she also had a physical injury and she needed physical therapy, and she did not know if that was covered or how to access the care for physical therapy.
So we're kind of in a double healthcare revolution in Oregon at the moment. In addition to the federal changes, we're in a state overhaul with a greater emphasis on the community care organizations. And David, I wanted to ask you how this works, how the community care model works for dealing with the homeless population.
Great, thanks. First of all, I just want to say it was a great report, and it really reaffirms my belief in citizen advocacy. So thank you all for pulling together a report that I learned a lot about. But I think the coordinated care organizations, which is, of course, Oregon's model for healthcare transformation, the premise behind the coordinated care organization is that we're dealing with a really challenging population. So we're dealing with the Medicaid population. CCOs are about Medicaid. And the definition of somebody getting on to Medicaid is that they have some relationship to poverty. They're around the poverty level. So as the legislation was put together around CCOs, people were saying this cannot simply be a medical model because there are so many social issues that determine a person's health outcome when there's certainly for people who living around and close to poverty, that you can't just solve it medically. And we know this actually is true for every level of the population, that the medical system doesn't hugely impact our overall longevity, in truth, and we could talk more about that. But they said that, look, we need to have a coordinated model and what you're coordinating is not only the internal pieces of healthcare, which is the silos that we have historically had between the physical health world, the behavioral health world, mental health and addictions, and in the dental health world, but those people need to work together. We need an integrated model, plus there needs to be a connection to community services because those community services are hugely important. So the coordinated care model is really supposed to be that model. I think that and so part of the legislative structure for coordinated care was that we had a community advisory council, that it's not just all of us from the healthcare delivery system sitting around a table deciding what we're going to do to them, but they are at the table in a certain sense too, the rest of the community is at the table. And that's an experiment which I think all the CCOs are still working on. How do you bring community voice and how do you bring the connection to community services in? I can say from the HealthShare point of view, partly because of the people who are around our board table, that the question of housing and homelessness has been one that has been on the table from the beginning. And we have many people around that table who really understand the issues around homelessness and housing, and so that has been a conversation. I can't say that we've solved the problem, because it is a really complex problem, as all of us who have read the report certainly now know. It's really a challenge to figure out how you take a complex social problem and make headway on it. One of the things that impressed me was the number of recommendations at the end of the report. There's not simply 5 things you need to do or 2 things we need to do that's going to solve the problem. So I guess in answer to your question, I would say we have learned something around how you take on a complex social issue, like how you take on the issue of reforming the healthcare system. There's lots of things that could be said, and we don't have time to talk about CCOs in general, but when you talk to CCOs and you go to say, well, what's different in your community? And I've done a fair amount of this. What people consistently say is, we never used to talk together. We all know each other, but we never sat down at the table and we never talked together. We didn't really know each other, and this is the healthcare leadership, and now we are talking together, and now we're problem solving together. And it took a couple years for people to really agree on things that they need to problem solve together. And we have a long way to go on that. But I think that the only way we're going to solve these kinds of social problems is bringing people to the table who have a stake in it and, in a certain sense, forcing them to come to a conclusion. The CCOs were not a choice. The CCOs were legislated. We have to have CCOs. If you're going to be in Medicaid, you have to be in a CCO. I think the same thing, we have to figure out how do we bring together all the pieces of the housing world together, and it may not be the CCOs are about the healthcare delivery system. How do we bring the social service system together in a coordinated way where people are really forced to take on the really heavy issues of social care that we need to face? If you look at the world in a really simple way, there's Health systems fail in three ways. They send people to the emergency room, they send people to the jails or the prisons, and they send people to the streets. And I think if we have a really good healthcare system, very few people are in the emergency rooms. If we have a really good mental health and social service system, there'll be fewer people in the jails. And if we have a really robust social service system, there won't be people on the streets. There is the last thing I would say is that one of the things we know about ourselves as a country is we don't really invest much in social services. There was a recent study that was done that said, if you look at social services and add them up, social health services, and add them to medical care services, how does the U.S. compare with other countries? And in fact, even though we spend more money per capita than anybody else and more per GDP than anybody else in the developed world, we don't spend more money on health than anybody else in the world. We're actually pretty middling. So, and if you look at what we spend on social services, we're not very impressive. We're way, in terms of developed countries, we're way behind the pack. So yes, we have a lot of money in healthcare, more than we need, and there's a lot of waste in healthcare. Somehow we need to figure out how we invest more in social services in general, because there's not enough wraparound services, and that gets to the housing and other issues. So I think we've got some things to learn from CCOs, but there's a lot of other issues.
Well, if I could follow that up for just a moment. On the philosophy of CCOs, and I'm sure everyone in this room has heard the governor's air conditioner speech. You know, the idea that if you've got an elderly person in a warm apartment, you can let her get congestive heart failure and send her to the emergency room for $50,000, or you can give her an air conditioner for $200. And the underlying assumption of that is that you're dealing with a population that you can somehow keep tabs on. So the question is, how does this philosophy and how does this approach extend to a population which is, by definition, unrooted and harder to keep tabs on? That was for you, too.
So I think, one of the things we have understood is that there are people who come into the healthcare system and we understand who they are. But there's a lot of people who come into the healthcare system and we really don't understand who they are and they don't do well with us. And that, I think, is the classic, what people we call high utilizers, super utilizers, the small percent of the population that use the vast majority of healthcare resources. And what we have learned is you have to really you have to go out to them. You can't assume that they're going to come to you and you're going to understand them in the context of a 40 or 20-minute visit. And so one of the things that we doing as a community at HealthShare is we've really invested in this outreach worker model where there are people in the primary care practices who go out into the community and find out what is actually going on with David, who keeps going to the emergency room or keeps having problems. And it turns out that...
I could explain that.
Thank you. I was actually thinking of you, but yeah, okay. but that, so it's, we have to get... be much more community-based in terms of our thinking in terms of healthcare. It's just not, we're not just experts sitting in our box waiting for people to come to us, and they come to us, we make a pronouncement, we give them a piece of paper, which is either a prescription or a referral, and we're done. That's not going to work. And so the walls of the healthcare system have to be much more permeable, and we have to go out as much as they're coming to us. And I think, Crista talked about trauma-informed care, and we can talk a lot about that, but the populations that we're dealing with have they've been dealt all the bad cards in the deck, just one after another. And I don't think we as providers have known that. And when you go to see them in their context, and their context could be a bridge and it could be an apartment, that's how you learn what the population needs.
Well, that gets directly to my next question, which I wanted to extend to Rachel and Leo, which is about the unique problems of this population. These folks are not simply homeless. They're disproportionately suffering from mental illness. They're disproportionately suffering from substance abuse. And I wanted to ask each of you about the problems this poses and about how we can effectively bring services to this group. Rachel?
Thanks, David, and thanks again to City Club for having me here and for producing this terrific report. I agree. I learned a lot reading it. I think one thing to note, I've been working at the Old Town Clinic at Central City Concern for about 10 years. And in those 10 years, I've never had a patient come in for a first appointment and say, hello, I'd like to learn how to better use my insulin. Or actually, what I really need is an air conditioner. I think there is, one of the primary issues here is we cannot take our usual medical model of here's your diagnosis, I will give you this diagnosis, and this is the treatment that I prescribe, and then you will go off and exercise or execute that treatment and things will improve. In fact, it's exactly the opposite. When we talk about trauma-informed care, I mean, I think that can be a fancy term and it can be kind of confusing, but to me it means exactly one thing, and that is you listen. And you listen, and you listen, and you listen. That's the way that you build engagement. That's the way that you build trust. That's the way that you actually, after maybe listening for 1, 2, 3, 10 visits, you start to get at health information and issues that you can actually do something, that you can do something with. I sort of joke often that when I meet a new patient, the most important thing to do is to just listen for the first 20 minutes, which is difficult in a 15-minute appointment. But I think that the most important thing, I think, is when someone walks in, often what they want is housing. And that's when you have this new golden ticket to healthcare, you suddenly have access to power, you have access to a person in power, and the first thing that they ask about is, can you help me find housing? And we talk about that for a bit. But once you back away from that, you realize the fundamental thing that you're trying to build early on is to provide someone with hope and to provide someone with a feeling of safety. And again, I think we can talk a lot about how you, in complicated ways, try to do medical management around medical and behavioral management around a host of issues. But the system change for me, from where I sit in the primary care clinic, is just having the time and having the flexibility and having the resources at the ready to just be available to listen and to build trust. And that catalyzes everything.
Leo?
Yeah, well, I just want to thank everybody for being here and out there listening and watching. I mean, this is a really huge thing for us homeless people, and I just really want to thank you, first of all. But, you know, to me, the thing is, why is it always a homeless person's fault? It's not always a homeless person's fault on this. You know, just like what you were talking about, you know, is when you go to a doctor and they start telling you this, and you keep saying to yourself as homeless person, no, that's not me. That's not what I'm about. That's not what I'm trying to tell you. And they're directly telling you, you got to do this, you got to do that. And you're saying, no, I'm not. Like, I'll be talking about my leg, and they're talking about, okay, well, your arm needs to do this, or, you know, something way off. And you're thinking, no, I can't do that. Homeless people get turned off by that. We talked about in the talking to other individuals about the sensitivity of the doctors. With this new healthcare, there's a lot of doctors that aren't used to talking to homeless people, aren't used to dealing with homeless people. And so all of a sudden, you know, I start pressing that, here, you got to do this, you got to do that, not really listening to what the homeless person is trying to say. And so the homeless person is like, well, you know, I'm not going to go back because of this. The other thing too is about the system in itself. There's a lot of homeless people that are, I will use the term gun shy. They don't want to explain, or they're too scared because they know they're going to be either yelled at or told directly that you have to do it this way. So they really don't follow up on their appointments. You know, they're really scared to go back or to, you know, go back to their appointments, or don't know how to speak on up. I talked to a lot of people about this, and when I was in, you know, when we were doing this survey and stuff, I told the homeless people, panhandlers, you know, homeless people out there, what I was doing. And a lot of them told me about their going to the emergency rooms and not really getting the quality healthcare that they really wanted. They were actually just kind of shoved around, you know, pushed around, and then kind of gave them a Band-Aid and said, okay, you're on your way, you're good to go, when they were actually saying, wait, no, I can't. In their mind, they really wanted to say something, but they were too scared to say something. I know they have social workers in there, and that's what I asked them about. Did you talk to a social worker in there? And they said, what's a social worker? I said, well, it's kind of like an advocate. They can speak up for you. You can listen, or they'll listen to you, and they'll explain different things. But I think, one of the biggest things, though, is that the homeless, it's not always the homeless person's fault. And that's what everybody tends to think. The homeless person, that's why you're homeless, is because of you. No, it's society sometimes that doesn't really comprehend of what's really going on. The follow-ups, it's another thing hard to get to, back to a hospital or to a clinic way across town, something like that, But to me, the Old Town Clinic is a really good source that really does deal with the homeless people and know how to deal with the homeless people. And that's one of the biggest things I think that the sensitivity is what we really need to do with the new doctors and the new people that are dealing with the homeless people. It's not necessarily their fault. You got to tend to look at how they're being treated.
Thank you. Makes me think of a doctor I once had who said his policy was listen to the patient. He's telling you what's wrong. And if I could follow up, we tend to talk about homeless as if it's a single population. And we know it's actually many different populations, and I'm thinking specifically of the difference between street kids and some other folks there. And I wonder if I could ask the two of you to talk a little bit about how different parts of the population present and how they need to be dealt with. Rachel?
I will admit up front, I work primarily with adults, and I work primarily with adults with really severe, usually end-stage disease states, either medical ones or psychiatric or addiction. And so I might focus a bit on that, and maybe Leo, if you want to take more talking about younger folks. So I have my sort of model in mind, which I would love to see someday as we think about, with new Medicaid dollars, how can we create healthcare which is attentive to the broad array of needs that people have. I think caring for people in the unit of a team as opposed to the unit of that, sorry for saying that this sounds sacrilegious, but the sacred doctor-patient relationship, I actually don't think serves patients very well when they are very complex and their lives are complex. You really need a team of people to help do that. And I've learned a lot from my colleagues in behavioral health who have done team-based care, which is not just focused on the person with the medical degree. They've done team-based care very well for very vulnerable patients for a long time. And those teams are multidisciplinary, they have resources at the ready, they are flexible, and as David mentioned, can sort of meet people where they are out in the community and are able to help find them in various places. So that's one key element, I think, of caring for particularly chronically ill adults really well. I think another thing is we still, in our system, because one of our incentives is to lower the overall cost of care, we still wait until people have failed everything and have ended up with pretty severe conditions, and frankly, they have to have hospitalizations or lots of ER utilization in order to access a lot of that high-intensity programs that we have that have a lot of case management, that have housing, that have these kind of flexible teams. And I would love to start working with really this sicker adult population. We can project, we can see when this is on the rise, and let's intervene there at the earlier stages before they get really sick and end up in the hospital. And if you'll indulge me for a minute, I have a patient I've been working with for the last year, whose name, oddly enough, is also David. And he is now 76 years old. He's homeless. I've known him for about 10 years, but his story got interesting a couple of years ago when he developed a new psychosis, kind of out of the blue, but it may have been substance related, and tried to hold up a McDonald's with a plastic knife and ended up going to the Oregon State Hospital with a 2-year commitment. Thought that this was a crime because of his psychosis. He was discharged 2 years later, and they told him, you know what, you actually don't have any mental illness, so just go back to Portland and go see your doctor, and you're cleared. So he took this as, he used to say to me, I graduated at the top of my class. So things went well for about 6 months, and granted, he's now 76. He's got pretty bad lung disease. He's got bad arthritis. And about sometime this summer, these flickers of mania started to come back again. I don't know if they were substance use or not. I said, you know, I'm getting kind of worried about you. He's losing weight. His speech was more pressured. Cold weather started to come. I tried to admit him into one of our recuperation care programs for homeless people with really severe medical illness. His Medicaid payer said, you don't meet medical necessity at this point, so we admitted him anyway. We kept him there for 4 to 6 weeks. He eventually ended up back on the street. He then started to go to the emergency room, but still not crisis where he would qualify for one of these really high intensity teams. He would come see me in clinic in crisis. I would try to cobble together resources for him. This went on for several months with him not qualifying for these programs, ending up on the street. A couple of hospitalizations, and he eventually, just on Monday, was admitted to the ICU with respiratory failure. And now everybody's at the ready and wants to rush in to help. And I think part of caring for a homeless, medically fragile, and psychiatrically and substance use fragile person is to try to understand that we can't wait until he's in the ICU with respiratory failure to get him the care that he needs. We can do this earlier on. And we have the models to be able to do it. We just need to transfer them to an earlier stage in somebody's life.
Leo, can you speak to you a little bit about the disparities and variations between the homeless population?
Well, I guess I can use my own experience, which is in 2004, I went to the doctor because it was hard for me to breathe. So I went there and they took, it must have been 10, 15 x-rays of my lungs, and which I thought was unusual because usually it's 2 or 3 that they take. So the doctor, when I seen the doctor asked, or he says, well, I guess you're wondering why we took so many x-rays. And I said, yeah. So he put my x-ray up and he showed me. He said, see this black spot on your lung, one side of my lungs? He said, 10% of it's not there, it's not working. I said, wow, really? What is it? What's going on? And he said, well, do you have insurance? And I said, no. And he said, well, we can do some stuff, and I really don't know what it is, but we can't do that much. Unless you have health care, then we can do something about it. So this was in 2004, and I was up in Seattle, and it was like a 10-year waiting list to get into health care up there. And also sometimes you had to get on a waiting list to get on a waiting list to get your health care. So when I came down here in 2013, I had the same problem, which was I couldn't go from here to that camera right there without having to stop. My whole body just froze. And I thought it was an anxiety attack because I was sweating, my heart was pounding, and my body froze. So through the VA, I went to the clinic downtown, and they told me to go, my primary care doctor told me to go up to the hill and get some x-rays. It took me about almost 2 hours to get on up there. And when I went to get my x-rays, the technician there was no doctors, but the technician told me to go to the emergency room right away. Should have been a 5-minute walk. Took me 20 minutes to go downstairs across the hall and get in there. Once I got in there, the doctor, they put me in the emergency room. hooked me on up in there with the heart monitor, breathing apparatus, and so I didn't know what was going on. But what happened was, when I checked in, there was 55% of my lung intake. That was what was the problem. I wasn't getting the full air capacity. Now, I think it's 95% that they have, it's the emergency. Mine was 55%. Later on, I found out that 30% of my lungs wasn't working. Same thing, it went from a 10% to 30%. I'm still on oxygen now, but I'm a lot better. But with the healthcare, that's the problem, is when these individuals out there, when you talk about this minor thing that they could have, healthcare and get on out of that situation, it wouldn't be as bad as what I had to go through and what other people are going through. This is what it's like out there in the homeless community. Right now it's great that they're having, healthcare and they can get these things resolved, but still, we're still kind of, I believe we're still kind of a long way from that. And I explained earlier why we are away from that, because it's the sensitivity and knowing exactly what's going on out there in the homeless community.
Thank you. In a couple of minutes, we're going to go over to questions from the audience, and we've got the microphone over there for folks who'd like to move in that direction. I'm going to try to sneak in one more question before we do that, which for David and Crista, which is one of the things that the report talks about is when someone is hospitalized, before he's released, there needs to be some arrangement for his housing. And I wonder if this is a considerable expansion of hospitals' responsibilities and how hospitals would actually be prepared to deal with that kind of obligation.
I'll just start with the example of why we made that recommendation. So again, when we talked to homelessness advocates, and also when we talked on the street with homeless individuals, we heard a few stories of people who had been admitted to the hospital, sometimes for major surgeries, and then released to the street when they didn't have any way to care for their injuries that they were being released for. So one example was a surgery at OHSU, and when they got back to the Right to Dream 2 encampment, they didn't have any way to care for their open wounds, and so had to rally with the other people who live in the encampment to find funding for a motel, and then finally ended up at the Central City's recuperation center, recovery center. So that was one example. We heard of other examples of more minor injuries where they were released from the hospital. And again, even an abscess can become a major life-threatening emergency if you don't have access to clean water and a warm place to sleep.
Right. All of the hospitals, I think, are aware of this issue. I mean, whether or not we're at the point as a community where we need to be, but all the hospitals are really focused on readmissions and making sure that people who have a plan, and there's staff in all hospitals at this point that do discharge planning, that try and link people to services. There is also the recuperative care program, which all of us have used for many years. It's a great community effort. It's actually a collective effort that the Central City organized, that all the hospitals and most of the health plans actually support it, because when somebody is ready for discharge and doesn't need the hospital, doesn't have a place to go, there needs to be the sort of next step unit, and that's what the RCP program has been very successful at doing. And of course, we need more and better and bigger and all of that, but that work is in place. One of the challenges, of course, is, again, the social service system, the social safety net isn't strong enough, and there isn't enough out there to send people to, even when a care manager acknowledges the problem, can say this person is going to fail. Many of the health plans actually will put people, I've done this, we put people in hotels, we put people in motels, we find all kinds of patchwork. But we have to focus on building that social safety net, which we as a country haven't done well at, because there's no there. I mean, and part of this, I think the report did a good job. It's hard to find housing in Portland for anyone, right? So if you're somebody with housing and you have housing stock that you're available, what are you going to do with it? And so there's a lot of competition for just the basic resource of a place to go. So that, and the hardest to house are the people we're talking about. They have to usually come with services. So that's even a scarcer resource. So we're not going to solve this without some major capital investments. And the point I was trying to make before about the amount of money we put in social services, if we took all the waste that's in healthcare, which some people say is 30%, which is a lot of money, that wouldn't be enough to make up the gap in social services that we need. So we have to rethink our priorities as a culture, really, to think about, are we willing to invest in people who need help, and are we willing to support people who can't make it on their own? And just to close, is this a moral problem? Because most of us, there's a strand in the culture that says being homeless is a moral failure, and that's your problem. You deserve that. But in fact, I think that the data in this report really says that's not the case. If you look at, one of the things that blew my socks off on this report was 30% of the homeless population that came out of the foster care system. And I checked that with somebody, and he said, yeah, I have a study in California that said 40%. This is not moral failure, folks. This is social failure. And so we are creating the homeless population because of the way we've structured society. And solving homelessness is not housing. Solving homelessness is going upstream to make sure we're not generating the next generation and the next generation and the next generation of homeless people. And that's a whole other conversation.
We go over to our questioners now. Please identify yourself as a City Club member and try to ask your question briefly. Thank you.
Hi, Dr. Roger Meyer, country doctor, City Club member. I would like to ask the panel how we improve our marketing to the people who are the most vulnerable and the most resistant to our care, and then how do we help them as we market to help them navigate the system. I've been practicing for inner city poor people for 60 years, and I think that's one of the big failings, that people are out there, but I think we fail as clinicians to really reach out and market to people. And then when they reach out, I love the Central City Concern presentation because they're doing it really well. And how can the rest of us reach out and market?
Rachel, you want to speak to that?
Thanks for the question. One thing that I've learned a lot from at Central City is that when we as care providers really reflect the community that we serve, about 50% of the staff at Central City Concern have lived experience themselves of homelessness, of addiction, of trauma, of mental illness. And so not only do those folks do a terrific job of connecting with clients who have that same experience, either out in the community or sort of in our settings, but they teach me. I don't have that lived experience. When I got to Central City, our janitor was my mentor. He had a ton, he's no ordinary janitor. He's a pretty remarkable guy, but he would pull me aside and say, "You're doing a terrible job." So those, I think if you can build, this is, I think, one of many possible solutions, but if you're able to build an organization that reflects the community that you serve, that not only helps to engage that community, but helps to train everybody else who don't know as well.
Well, I just like to say also with the outreach too, we need to do a lot of outreaching out there. There's a lot of individuals that can't get into the city here in Portland that need it further on out. Outside in, I got it right. Yeah, outside in is a good one. There's the meals that's under Burnside Bridge. They have a mobile home that has the dentist and also healthcare there. I mean, that's what we need also is the outreaching too. It's great that these organizations are doing this, but we still need to get further on out. And like it was said earlier, go to the people too, the homeless people.
Next.
I'm Paul Anthony. Since the needs are different and the resources available are different, could the panel please speak to the need for dental care and what resources are available? Thank you.
Crista, do you want?
I do not. Oh, sure. Well, I think we're fortunate now that we enfranchised the dental community into the healthcare system and the CCOs. I mean, they're not that separate thing over there, and we're now talking together. So I think that we have the chance to really talk about population health that includes dental starting early in life. It's really important. What Rachel and I were sidebarring about is they have a wonderful dental clinic sponsored with Multnomah County in Central City Concern, in their primary care and mental health integrated care system. And I think we've got to bring the teeth back to the body, or the rest of the body into the teeth. I don't know what the formula is, but we got to put it all together because it totally makes sense. I mean, I certainly have to say, as a primary care physician, really underappreciated the importance of dental care and the effect of poor dental care on general health. And I think we now have a model in Oregon where we're going to make some progress on that. And we need integrated models. And I think that the point is extremely well taken. We can't just look at one part of the system and think that or one out that's separate.
Next questioner.
Cameron Witten, City Club member. For a significant time now, we've seen transformation in how we look at healthcare and transformation in how we provide healthcare. And it's really great that we're talking about this as an intersection, because there's a lot of potential as well for us to see transformation in how we look at and how we provide services to eradicate homelessness. And so I guess, the potential that I see right now is coming a lot through a Home for Everyone. And I love to see, if you guys could talk about, what is that and how we see what's behind this paper, the urgent recommendations behind this paper. How do you see that might actually fit together?
So thanks, Cameron. The Home for Everyone Coordinating Board is an organization that's just started fairly recently, and it's a collection of social service providers, housing providers, the county, the city, Home Forward, and a few others. And they're really looking to increase and improve on services to the homeless population, as well as others who are low income or disenfranchised. And so I was at their meeting on Tuesday, and at that meeting they were talking about the ways of looking at reducing homelessness in particular for veterans. And it was really informative to be part of that conversation. I do think that there is great potential for the Home for Everyone board to start taking on some of these social service issues that were brought up in the report and make progress on them, similar to how the coordinated care organizations are making progress with health care for Medicaid recipients.
Next.
Kurt Wabring, member. Your report indicates that 40% of the women who are homeless have experienced domestic violence. So I have, first a comment. Obviously, more housing is an underlying recommendation that you have. We just don't have enough places for people to go, so they're on the streets. But I'm wondering if you found that there were any significant differences with women who experience domestic violence in terms of their needs.
Rachel?
I can, particularly around emergency shelter, it is profound, the need for women. We have a handful, I think 2 or 3 places that we call upon regularly for women in very acute crisis, but even homeless women not in acute crisis. And that's, again, that system is not one that I have much influence over as a primary care provider, but that's something I see every day, women in crisis, and we don't have a place for them to go. I think from thinking more about the medical, sort of how do you provide health care for those folks? Again, this is where the trauma-informed care becomes such a big issue. How do you do good reproductive health counseling and examinations in a trauma-informed way for women who've experienced violence? There's lots of research around what happens to your brain chemistry when you're subjected to trauma again and again, and how rapidly people escalate and respond to situations. And so understanding how you have difficult conversations and do some of the difficult negotiations that happen in primary care, that happens a lot as well. But I would emphasize, just from my first response to that is, boy, do we need more emergency services for those women.
Just to add something to that, it's not just domestic violence. If you look at who's in the population of homeless people, we find, and there's been a huge research on this, that these are people who generally have had really tough lives starting in the beginning. So a lot of neglect, a lot of sexual abuse, a lot of physical abuse, failure in school. Very few people are graduating high school. A lot of incarceration. A lot of the crossover with the prison system and the homeless population is huge. So this is, as I was saying, these are people who have been dealt all the bad cards in the deck from the beginning. So this is a traumatized population, mostly starting in really early life. And one might say, in a civilized healthcare system, we would be identifying that early, and we would be responding to that early. We'd be screening for that. I can honestly say we haven't been doing that, and we need to do that. But this is a traumatized population, and really what we're talking about in terms of helping a homeless population is recovery. And I've always learned from Central City, because they work in health in a recovery model. They're not a healthcare system so much as I've learned, is they're a recovery system. And these are people who have been socially marginalized, socially traumatized repeatedly over years and years and years. And we're not going to fix them with a prescription. We're going to have to fix them with a long-term investment in their return to well-being. So that's what the population is, and we are creating this population by the way we've structured society.
I just want to make a comment on that. Again, when I started up in Seattle, I used to work with Chief Seattle Club, which is a Native American day shelter for homeless Native Americans. And being on the streets, yeah, you do get traumatized there a lot. There's a lot of things that homeless people have to do, which is push all that anger, all that hatred, all that down. We have to be content with everybody taking our property, our safety gear, the places that we sleep, being pushed out in the rain. We all have to be content with that and not voice our opinion of, well, this is really bad, because then it comes a backlash. We get thrown in jail. So one of the things that I asked, or I had talked to the executive director, was I said, well, look, what we need to do is get these individuals and get them in what we call, Native Americans call a talking circle. They all get together in a circle, and they have an eagle feather, and whoever has that eagle feather can vent on out. And, she just kind of brushed it over her head, whatever. A couple months later, I went back, and she was all excited. She goes, I did it. And I was like, what? I forgot all about it. She said, well, there was a lot of deaths in the Native community. She said, so there was a lot of, the tension was so thick, you could, cut it with a knife in here. She said, so I got everybody together, and she said, what we can do is just talk about this. I set a time for everybody. They could dance, they could pray, they could talk about this, all of this stuff that needed to get on out, vent on out. And it worked, she said. She said the tension went way down. So then we started a group there, in that, where she wanted to bring in therapists and all this other, and I said, no. That will just kind of intimidate them. I said they need to be by themselves so that they can talk. You can have the therapist on the outside if you do need them, but homeless people can talk and they can vent on out. I mean, they're human beings. They're not little kids. They can work for themselves on this issue, and that's what we need to do, is, have stuff like that where people can vent on out. I've seen it many times in shelters in 10 cities where they do that. Somebody comes in sad, mad, or whatever, and the people are like, hey, wait, what's going on? And when the person tells the other people what's going on, then they say, oh, well, I went through that too, or I seen the doctor, and you should go see this person. I'm either going through it now, I've been through it, and all this other stuff. So, that happens in the homeless community, and a lot of people don't realize that that's what's happening out there. They are taking care of themselves. And excuse me for saying, but, a lot of the people don't understand that are, in the organizations.
I think
they don't see that stuff.
We're running out
That's what we
here.
need.
Thank you very much, and please thank our panel for a remarkable discussion.
We have run out of broadcast time for further questions, and we'll have to stop for the day. City Club members, please stay in the room for the debate and vote on health care and homelessness report. And as we close for today, please join me in offering our sincere thanks to Friday Forum Committee member Felisa Higgins, who produced today's program, and our speakers, Crista Gardner, Rachel Solotaroff, Leo Rhodes, David Labby, and David Saracen. Thank you.